Antibiotics are critical, life-saving interventions for severe bacterial infections, but they operate as blunt instruments within the body. Systemic antibiotics inflict well-documented collateral damage, stripping away layers of the established gut microbiota alongside the targeted pathogen. Physicians often prescribe these medications defensively, even when the exact long-term costs to the patient's microbiome remain clinically ambiguous. Prior studies investigating a connection between this systemic disruption and the onset of irritable bowel syndrome have yielded heavily conflicting data. The central clinical question is whether post-antibiotic IBS represents a generalized risk of exposure or if it depends heavily on specific isolatable clinical variables. If the risk of IBS is treated as a uniform side effect of any antibiotic use, clinicians may be overlooking evidence of much more specific, site-dependent dangers. Researchers Luigi Colecchia and Giovanni Marasco recently conducted a systematic review and meta-analysis to resolve the inconsistencies in prior literature. This visual maps out their massive dataset, compiling 31 distinct studies to track over 422,350 patients across multiple countries. The methodology isolates the incidence of new IBS diagnoses by dividing the pool into two distinct cohorts: 244,632 antibiotic users and 177,718 non-users. To maintain rigor, researchers strictly excluded anyone with a prior IBS diagnosis, ensuring the analysis only captured new-onset incidents. The longitudinal tracking in these studies captured long-term patient outcomes, with follow-up durations ranging from 6 to 204 months. Across all included data, the aggregate findings showed a pooled incidence rate of IBS at 26% for antibiotic users versus 20% for non-users. An absolute difference of 6% appears moderate in isolation, but when scaled across a national or global population, it represents tens of thousands of iatrogenic chronic illnesses. This chart compares those aggregate rates, revealing a pooled incidence rate ratio that indicates a 30% higher baseline risk for new-onset IBS among antibiotic users. This 30% metric carries high statistical significance, formally establishing a link between systemic antibiotic use and IBS. The analytical roadblock appears in the statistical heterogeneity. The pooled data shows extreme variance, with the I-squared value reaching 100%. Clinically, an I-squared value that high indicates the variations among the 31 studies are too massive to be random chance. Hidden variables are heavily skewing the outcome. Relying on the 30% generalized risk metric is clinically insufficient because it completely fails to explain why the data remains so volatile. The researchers used sensitivity analyses to cut through the noise, carefully stratifying the data based on the specific location of the patient's original infection. To identify the true threat, physicians must look past the systemic average and track the exact biological pathway of the initial pathogen. This decision tree maps the separated data, starting with the cohort of patients prescribed antibiotics for non-gastrointestinal infections, such as respiratory or skin conditions. For this group, the statistical association between systemic antibiotics and an increased risk of IBS entirely vanishes. Prescribing systemic antibiotics does not inevitably cause lasting IBS if the underlying infection is located elsewhere in the body. The data pivots sharply when we isolate the second clinical pathway: patients prescribed antibiotics specifically to treat gastrointestinal infections. In this isolated cohort, the risk of developing new-onset IBS skyrockets by 71%. The primary structural limitation of this meta-analysis is that many of the included studies were retrospective. Retrospective designs inherently introduce recall bias and selection bias, which clinicians must factor into their interpretation of the final numbers. The original studies also inconsistently reported unmeasured confounding factors, specifically patient diet, genetics, mental health, and concomitant medications. Despite these variables, the sheer statistical weight of a 71% targeted risk spike survives the limitations and demands an immediate shift in clinical practice. The biological mechanism behind this data relies on the specific chemical interaction occurring within the gut. A gastrointestinal pathogen already inflicts acute trauma on the site, triggering local inflammation and destabilizing the mucosal barrier. Introducing an antibiotic into this volatile environment acts as a secondary, localized scorched earth event that eradicates the surviving commensal flora. The original pathogen's physical trauma combines with the antibiotic's severe microbiome depletion to permanently alter both gut motility and sensitivity. Treating a GI infection with antibiotics subjects the gut to two distinct biological traumas simultaneously, heavily predisposing that precise location to chronic IBS. The study authors maintain that physicians should never withhold essential antibiotics during severe, life-threatening bacterial infections. The clinical target of this data is the casual, unnecessary, or overly broad-spectrum use of antibiotics, specifically during periods of localized gastrointestinal distress. The immediate short-term benefit of a broad-spectrum prescription must now be mathematically weighed against a confirmed 71% increased risk of iatrogenic illness. Physicians need to immediately integrate this site-specific risk stratification into their differential diagnosis and prescribing habits. Cautious prescribing serves as an active, individualized patient protection strategy, moving well beyond a general public health measure designed to prevent antibiotic resistance. Protecting long-term gut health requires recognizing exactly when a localized cure risks becoming the active catalyst for a lifelong chronic condition.